In this case, if I'm not wrong, red is good and blue is bad. What's the golden ratio here? How do you... Yeah, at home I couldn't imagine injecting myself with something. I'm scared of those things. Call me straight logic, but if I can't eat as many oranges, I won't have as many vitamin C. Hello everyone, welcome to All About Health, the show in which we speak of all things about health. Today we're here with Dr. Untitled Chapter, the bariatric surgeon. Welcome, doctor.
Hi.
How are you feeling? Is everything okay?
Everything is okay.
You've had a busy day today, yeah?
Yeah, it's a busy day. Lots of operations, you know.
Exactly. Thank you for taking the time to be with us.
Oh, not at all.
Today we wanted to ask you about bariatric patients where you specialized in. So these patients, before doing the surgery, would they need to take any precautions? Is there anything to watch out for before undergoing a gastric sleeve or a gastric bypass surgery?
Bariatric procedures are generally safe and effective, but can be associated with devastating complications, some of which may be fatal if not diagnosed quickly. Especially the patients have to cut some medications like oral contraceptives.
So birth control pills, you have to lay them off before the surgery.
Exactly. Plus oral anticoagulants, you have to cut it.
If I'm taking a daily aspirin, I can't go on.
Yeah, you have to cut it 7 days before the surgery if you have aspirin. But if you are under Plavix, you have to cut it 5 days before surgery. It changes.
I see. So the best is to know what the anticoagulant type I'm using, to reach out to my doctor.
Yeah,
and
the doctor will say you.
But oral contraceptives, they're forbidden for a week or?
They are forbidden for their thrombosis risks. This means increased blood clotting.
We want patients to stop using them 2 weeks or 10 days before the surgery.
It is recommended, 2 weeks before the surgery.
There's also a special diet, a last day diet, which is easy to apply. And then they're here, then the patients are here, then they undergo the surgery. You said that this surgery, gastric sleeve and also gastric bypass, they induce some risks.
There are some complications, early complications and late complications. Early complications include leaks, leakage risk, and bleeding risk.
So leakage is when the stomach isn't closed properly, yes?
Yeah, we are cutting properly, but it changes person by person to heal.
And the tissue softness changes for each patient.
Tissue healthy and tissue healing is changing by person.
But I heard that we use tri-staplers now, and there's no need to do the work of the stapler manually like the old days.
Yeah, there are so safe materials. They send 3 lines of staple, the one of the gastric side and the other side, 3 of them.
So both sides are sealed.
Yeah, both sides are sealed.
But this risk of leakage, that can still happen in the second day post-op during the first month, they say, right?
Yeah. In the late term, we say 30 days, in a month. Mostly we see it between 5th day of the surgery.
The majority of the time is when the patient's already here in Turkey, even if they're traveling from overseas.
Yeah, when they're in Turkey.
And you can guide these through, you can follow these and make sure the patient doesn't have any risk with blood results, or you also have a leakage test.
We have a test for the leakage. And anastomotic leakage is the most dreaded complication of any bariatric procedure because it increases the overall morbidity and mortality, which means increasing risks of procedures. And how can we suspect leakage? When the leakage occurs, the patient may feel heart palpitation, which means in medicine we call tachycardia, which means the heart rate is over than 100 beats per minute.
You feel your heart speeding.
Yeah, if you feel heart palpitation and also difficulty on respiration, shortness of breath, we call in medicine dyspnea. And also you may feel fever and abdominal feel. These are good indicators of leakage. What do we do against leakage? We place a drain during the surgery next to the stomach. 2 days after this operation, a 100 cc methylene blue water is drunk by the patient. Let's be oriented with anatomy. If the patient drink some water, blue water. It goes into your esophagus and into your stomach, and which the drain is next to your stomach. And if there is a leakage, the blue water comes to your drain.
So in the drain tubes, I'm used to seeing the red color, the body liquid secreted after the surgery.
Yeah.
In this case, if I'm not wrong, red is good and blue is bad, yeah?
Yeah.
I got something for you. So this is the methylene blue water we spoke of. The patient in their post-op second day, that morning is when they drink this, and only after having drunk this and we find that it's still red, so it's still healthy,
Yeah.
that's when we start the liquid diet, right?
Yeah.
The dietitians tell me all the time that if the patient doesn't do the liquid diet properly, eats solids instead in the first month, and doesn't do the diet plan, there's an increased chance of leakage, because the still healing stomach is vulnerable to any pushes inside or so.
In the postoperative second day, if there's a leakage, we can see the blue water in the drain. So if we see the blue water, we can start the medical therapy earlier when the clinical condition of the patient is good, if there's a leakage. So this approach prevents major interventions like an operation, like an endoscopic intervention, and it reduces the risks. Also, every day we monitorize the blood tests like hemogram and CRP. These are the good indicators of leakage.
I see you guys every morning, you speak of the values and you say they're good values, they're bad values. I never get them.
Yeah, we always measure CRP level and hemogram. We monitorize more closely.
So to sum up, if I understood correctly, the leakage risk is a major one. It's almost fatal in some cases. But it's the best is to indicate this early on when this is happening, so we can interfere earlier.
Yeah.
And these don't always call for a second surgery, do they? Sometimes you can fix it with an endoscopic approach, and sometimes without any anesthesia, without any surgical touch, they can resolve themselves.
Yeah. If we can diagnose earlier, we can give some medicine like antibiotics, and after that, patient will be good.
So I heard you say the patient should stop using anticoagulants so that the blood is not too thin for the surgery date. But you also said they have to stop oral contraceptives because the blood shouldn't be too solid for the surgery day. What's the golden ratio here? How do you...
There's a risk of bleeding after the procedure, and there's a risk of thrombosis after the surgery. Thrombosis means increased blood clotting, and bleeding means a decrease.
Loss of blood.
Yeah, decreased blood clotting, which means loss of blood.
But blood clotting is also dangerous, right? Because it can travel through the veins and it can block somewhere important.
They are also existed in your legs, in the deep veins of your leg, and it can be goes to your pulmonary artery, which means your lung main artery, and the branches of lung artery, which makes respiration difficulty, shortness of breath, and decreased oxygenation of tissues. This is so dangerous condition for the patients. Incidence of bleeding in these patients is about 1%, the bleeding risk.
It's not that high.
Yeah, but fortunately, about 85% of patients are likely to stop without surgical intervention, just medical therapy.
If I were a patient, I'd prefer blood loss to blood clots, because blood clots, you never know what's traveling around your body. But with blood loss, I lose a bit of blood. I'm here with the doctors. They can put a transfusion of blood.
Yeah, we can. Yeah, exactly. You can transfuse some erythrocyte suspension, which means blood. Postoperative bleeding that requires intervention in up to 10% of our patients. So we provide a close follow-up of bleeding with blood, hemoglobin levels, some blood tests.
So the liquidity of the blood should always be supervised so that we never risk going too solid or too liquid.
Yeah, it should always be measured. The one side of problem is bleeding. The other side of problem is thrombosis, increased blood clotting. Like every abdominal operation, there's a risk for thrombosis in bariatric surgery. Also, obesity increases the risk. Thrombosis mostly occurs in 2 or 3 weeks within the surgery, but there is no consensus about the optimal duration of blood thinners. It changes doctor by doctor and clinic to clinic.
And maybe each patient should have a different...
So we recommend and prescribe an oral blood thinner, which is easier to use compared to injections. The duration of hospital stay. We are giving patients blood thinners, some injectors. This is hard to use.
Yeah, at home I couldn't imagine injecting myself with something. I'm scared of those things.
At home, patients are likely to be used the oral prescription, oral blood thinners.
I think you brought some examples here.
Yeah.
Now you're making me feel bad I didn't get you anything.
You can open the bag. Yes. This is our blood thinner, an oral blood thinner.
So these are provided to patients here at the hospital.
Yeah.
And we ask them to use it for how long? It depends on the patients. For some patients, I heard you saying don't use this at all because they have quite liquid blood altogether. But sometimes you prescribe patients to use this for a while.
We recommend 10 days of these pills, a pill for a day, 10 days after it's finished. Maybe some doctors
may prescribe for longer, and
for
depending
longer.
on the patient.
Patients have thrombosis, maybe, or maybe bleeding. We should cut the blood thinners. It's a personal condition.
Of course. So after undergoing the surgery, you prescribe blood thinners to the patient so that we avoid the risk of blood loss through an over-liquid blood, maybe, to say it rightly. What you do here with the patients, the type of this surgery is intervening with the absorption of nutrients. And I've seen it firsthand. After you operate them, they start losing weight. They can't eat as much, and don't they need the food in a way? Like, I see them getting skinnier all the time. Are we sure they're not missing any main nutrients, any minerals? Because these could be problematic in the future.
Yeah, you're right, exactly. There are malabsorptive operation types and also restrictive operation types. Malabsorption means it reduces your absorption of the nutrients. So, yeah, you are right. It decreases absorption to take important nutrients. For example, vitamins, for example, minerals. It was reported that vitamin deficiencies and also mineral deficiencies are more common in malabsorptive surgery. Yes, we know that, but not only in malabsorptive surgery, also in restrictive surgery like sleeve gastrectomy.
So during a bariatric surgery, you said it was malabsorptive, so it was cutting down the absorption levels of some nutrients, and it was restrictive, so in some of them, most of them, the stomach size is being reduced, or the stomach size that's used in the digestive process is reduced to a percentage of its original size. I'm wondering if these would cause any deficiencies in some nutrients, some vitamins, because call me straight logic, but if I can't eat as many oranges, I won't have as many vitamin C.
Yeah, you're right. We will see especially vitamin D deficiencies and calcium deficiencies, iron deficiencies, and also vitamin B1 and B12 deficiencies in all bariatric surgeries. Yes, it's more common in malabsorptive surgeries, but we can see in the restrictive surgeries like sleeve gastrectomy. Therefore, regular follow-up of patients after surgery is needed, and it's very important. So, what can we do for this?
Because they leave in a week, and how are you going to take the blood test when they go home?
We prescribe a vitamin and mineral complex, nutrient complex, for 2 months for every patient in bariatric surgery, and then re-evaluate after 2 months. And because it changes person by person.
Some patients I've seen, after the surgery, they don't take any supplements and they don't need them for the rest of their lives.
Maybe they won't need any supplements. Yeah, you're right. But during the first 2 months, yes, everybody have bariatric surgery needs the supplement. For this, we prescribe and recommend some nutrient complex, a pill a day. For
These are going simple. A pill a day of this,
2
a pill a
months.
day of that.
Yeah.
Good.
After the 2 months, we can reevaluate.
I see. So this one, we ask them to use for 2 months, and every 3 months, I think, we ask patients to send us blood results anyway.
Yes, every 3
So
months.
now I'm getting why. Then you can look and see if they're missing any nutrients, and if they need, you can prescribe for the future.
Yeah.
And you check back in another 3 months, right?
Yeah. For example, in vitamin B1 deficiencies, thiamine deficiencies, we can see some weakness in the legs of patients. For example, vitamin B12 deficiencies, we can see anemia, some mind problems, some brain function problems in the
These are-
severe B12 deficiencies.
Okay, so this is a thing to watch out for. Like, it's
Yeah.
not just a vitamin B, I can take it, I cannot take it. It's
Yeah.
the first 2 months, as I understand, they're crucial.
Yeah, these are very important things of the surgery.
After the surgery, to cut out the risk, you prescribe some medication. I think one of the most important thing, because we always say the stomach keeps on healing for the first month after the surgery until the leakage risk is completely gone. Within that time, we always tell the patients to watch out what they eat, watch out what they drink, the contents, nothing acidic or so on. Is there a way to protect the stomach in a way?
And we also have and prescribe and recommend stomach protection pills for 2 months, a pill for every day. It is recommended not just after bariatric surgery, but also in every major abdominal operations. You have to take this stomach protection pills. We can show
This is not
like
a prescribed pill, right? You can get this over the counter.
Yeah, you can take these by yourself. The abdominal operations have some stressful times, you know. It's an operation, it's a trauma. It increases the acid mechanism of stomach. So we have to reduce the acid excretion of stomach. So the patients on bariatric surgery have to take a pill
I see.
for a day after surgery.
So this is to regulate the stomach acidity.
Yeah, it regulates,
And if patients don't use that, they might be looking at some reflux or some heartburn.
Heartburn, pain, especially reflux.
Heard what the doctor said, don't miss out your stomach protectors. And what else?
And also, we have to talk about analgesia painkillers.
Ah, of course.
After surgery, patients have strong feeling of pain, you know,
Sometimes a pressing pain in the chest
pressing
area.
pain. We recommend some painkillers for during the postoperative period, postoperative course. In hospital, we have to give some painkillers.
You give it yourselves, yeah?
In hospital, for the hospital stay, we are giving the most strongest painkillers
From the veins, so that
from the veins,
it's
like
regulated.
morphine, like paracetamol. But after surgery, after hospital stay, when they will be discharged, they should be used only paracetamol. We recommend like that.
I see.
Because paracetamol less hazardous conditions.
The least dangerous. And when the patients leave the hospital, I think the painful days are over.
Yeah.
The first day, the first hours after the operation, yes, I always tell the patients to watch out for those hours. But after the first night, when they sleep and then wake up again, and if they keep the second day walking, most of them don't need painkillers from then on. Is this mandatory to take these painkillers after the surgery?
They are happy commonly in the postoperative second day, third day.
So is this mandatory to take these after the surgery? Because some patients tell me they're fine in the third day post-op, fourth day post-op. They don't need painkillers.
It's not mandatory after hospital stay.
So this is not once a day, not 2 times a day, only if there's pain.
Yeah,
And if
only
not,
if-
it's best to leave them.
If needed.
We also apply a heavy medication here, especially painkillers, anti-sickness medicine, and also antibiotics. Do patients continue the usage of antibiotics after the surgery, after being discharged from the hospital? Or is all of it applied here and then they're good to go?
For during the hospital stay, we are giving antibiotics for every patient after being discharged. We prescribe 3-pill antibiotic. Only 3 days after surgery, one pill for a day. 3 days after discharge, the antibiotic will be finished.
So this all happens during the week in Istanbul for a foreign patient. If they came, spent 3 days in the hospital, and then 3 more days at the hotel, and when they return for the checkup, they'll be done with the antibiotics already.
Completely done.
But those, I'm afraid of these. Huh? They're big pills to swallow.
Yeah, there are big pills, but there's line in the center of the pill. You can divide
easier.
to swallow easier. You can divide it.
Okay, because I was wondering, we ask patients to feed with only liquids for 15 days after the surgery, and then we hand them a hard pill. It's not risky, right, to use oral medication after the surgery?
Yeah, it's not risky. They were controlled by some examinations. Almost every pill melts in gastric tissue. These are not dangerous pills.
Good. Thank you for your first time on the show. I know we'll ask you to come on a couple more times because there are things we wonder about. And once we find someone who knows, it's good to talk.
So appreciate it.
And thank our audience. Thank you for being with us. This has been All About Health with Dr. Said Dalkilic. We'll see you on another time. Bye.
Bye.